Let's talk about chronic obstructive pulmonary disease or COPD. When we say obstructive, we're talking about the physiology of the lungs in this disease. And there's two types of abnormal lung physiology. There's restrictive and obstructive patterns. In a restrictive physiology, there's difficulty getting air into the lungs or breathing in. And with an obstructive physiology, there's difficulty moving air out of the lungs, breathing out. So in COPD, there's two big reasons why this happens. Number one, you get mucus hypersecretion, and mucus plugs up the airways, causing air to get trapped distally in the lungs, so it can't make it out. So this causes hyperinflation. And then you also have loss of elasticity, generally because of free radical damage to elastic proteins caused by cigarette smoke. And that loss of elasticity, the elastic fibers in your lungs keep your airways open while you're exhaling. So when you lose those elastic fibers, the airways collapse. And again, air gets trapped in the lung. So there's kind of two pathways through which you can get air trapping in COPD. And it's very common for people to have a mixed phenotype with a little bit of both elements. But broadly, those two pathways are called chronic bronchitis, where you get mucus plugging, and emphysema, where you get loss of elasticity. So we'll go through a case presentation, then I have my own slides, and then we'll talk about this SDL. They give you a 66-year-old man with a 47 pack year smoking history coming in with a chronic productive cough for the past 2 years. So they're telling you that he has chronic bronchitis. He meets the criteria for chronic bronchitis. On presentation, he has tachypnea and he's in moderate respiratory distress. And you examine him and you find decreased breath sounds bilaterally. That's what poor air entry means. And you find expiratory wheezing, and you notice that he's got a barrel chest too on exam. And all of those are indicators that this patient has air trapping in the lungs. That poor air entry, especially the distant breath sounds, as your COPD progresses, your alveoli dilate, and there's just less entry because of, again, bronchospasm, bronchial plugging with mucus. So that's what the decreased breath sounds are attributable to. And then you get a chest x-ray and he's got increased AP diameter. That's also classic for COPD. You get spirometry on this patient. He's meeting all the criteria. He's got a decreased FEV1, decreased ratio, and it's non-reversible with administration of steroids, so it's not asthma. And lung volumes, not capacities, show hyperinflation, increased TLC, increased RV. So they are giving you every possible thing they could put in a question stem to show you that this patient has COPD. So that's what it'll look like on the exam. What we know about COPD and how we treat COPD has been built up steadily since about the 1960s, and current practice guidelines are based on a couple of different main sources. Primarily, there's the GOLD report, and GOLD stands for the Global Obstructive Lung Disease Initiative. And they have a website. They publish their report. You can go get it for free. They publish it annually. And the last time it received major revisions was 2023. But regardless of if you're primary care or a hospitalist or a pulmonologist, this is going to be your go-to text. This is going to be your gold standard, pun intended, for diagnosing and treating patients with COPD. Now, the American Thoracic Society also has a lot of information and their own independent guidelines from Gold. And we'll talk about that a bit more later, but I wanted to show you what their website looks like just because they've got a lot of different resources on a lot of different aspects of care. So, how do we clinically define COPD? We define it as an FEV1 over FVC ratio of less than 0.7, and that's according to the GOLD guidelines. And your FEV1 is your forced expiratory volume over 1 second. So it's how much air you can breathe out of the lungs in 1 second. And again, if you have obstructive physiology, you have difficulty moving air out of the lungs. And so that number is going to be diminished. And then we have your FVC on the bottom, which is your vital capacity. And your vital capacity is basically how much air your lungs move in and out with one breath. And here's the classic volume capacity graph. A capacity is just two or more volumes added together. And I've marked vital capacity in red here. And you can see that it's basically all the air that you can breathe in up top at the peak. All the way down that volume of air to the maximum amount of air you can expire out down there at the trough of the graph. So your vital capacity is the volume of air in one breath. And if you look at a flow volume loop that you would obtain with spirometry, your FVC is just the total volume of air moved in one breath. So you can look at a flow volume loop and get a ballpark for their FVC just based on the shape of that graph. And when you have these physiologic defects, again, they indicate you've got difficulty moving air out of your lungs. And as we said, COPD is characterized by air trapping. There's air trapped in the lungs for one of two reasons. There's mucus plugging and there's loss of elasticity causing collapse of airways. And this manifests as hyperinflation of the lungs, and here's what it looks like on a chest x-ray. You can see that the diaphragm is flattened, the lungs are very large, and this is a very hyperinflated lung field compared to what you'd usually see. So COPD is caused by cigarette smoke, mostly. You can get it for other reasons. You can get it from really any inhaled, foreign substance that's, non-physiologic. You can get it if you have alpha-1 antitrypsin deficiency. That's pretty rare. We won't talk a ton about that. Um, but with cigarette smoke, when you inhale smoke, there's some big changes that occur in your bronchi, so in your kind of medium to small airways, and then in your alveoli themselves. Let's talk about those now. The bronchial changes that you get are you smoke is particulate at a very small level, so those particles cause friction against your airway, and that friction causes a reactive production of mucus. So you keep smoking, you keep generating more mucus to lubricate your airways to buffer against the friction and irritation of that inhaled smoke. And this is the Reed index, which is the ratio of your submucosal glands, mucus producing glands, in your bronchi relative to the total width of the bronchi themselves. And so the gland here is marked in green, and the width of the bronchi is in blue. And a pathologic Reed index is anything greater than 50%. So you can just eyeball this histology and tell that the submucosal gland is occupying over half of the thickness of the wall of the bronchi. So that's what it would look like in COPD. Cigarette smoke inhalation also causes goblet cell hyperplasia. We know our airway has a stratified columnar ciliated epithelium. You've got a mucociliary escalator that helps with clearance of mucus. And goblet cells make the mucus. The ciliated cells move it up. And here's a image from a paper in which they stained some cells of the airway with a mucin stain. And you can see that in the control versus the COPD stain, there's a lot more goblet cells lighting up with that mucin stain in the COPD slice, and it's a big difference. And here's another image right here, more grossly, less so relying on the stain here, but you can tell that there's a bunch of goblet cells in the lining of the airway of this COPD patient versus this control patient. Here's a goblet cell, maybe here's a goblet cell, but they're much more sparse. They're much more rare. Ciliary cells make up the majority of the lining in this control airway versus COPD, where goblet cells make up the majority of the airway lining. And then finally in COPD, you can get squamous metaplasia because again, smoke is a mechanical irritant. And so if there's friction along this ciliated epithelium, then it's going to over time change into a squamous epithelium because squamous cells are smooth on the outside and they're a little bit sturdier, more robust, less fragile. They can withstand friction. That's why we have them on the outside of our body, on our skin. So airways change to a squamous epithelium over time as they're exposed to smoke. And you can see here, normal airway, goblet cells, ciliated, abnormal airway with squamous metaplasia, very flat on top. It's practically like skin. And so this is how people get squamous cell cancer of the lung. They get it in, one of their main stem or just off the main stem bronchi. And it tends to be centrally located because that's where this squamous change is occurring within, the walls of the bronchi, not down in the alveoli. So I just want you to understand this is how people get squamous cell lung cancer from this squamous metaplasia. And then also in COPD, we see alveolar changes. Generally, they're just hyperexpanded, and you see a loss of uniformity. In a nice normal airway, as we have pictured here on the right, you should see a bunch of alveoli that are all relatively the same size. But in COPD, as we have pictured here on the left, you can tell that some alveoli are normal and intact, but others are massive in comparison, 5 to 10 times the size of other alveoli. And that loss of uniformity and that heterogeneity of size of the alveoli is what clues in that you're looking at COPD on histology. So how do we make the diagnosis? Let's talk about diagnosing COPD. Everybody who graduates medical school should be able to do this. First, you look at the FEV1 to FVC ratio, and that'll tell you if they have it or not, according to the GOLD criteria. Now, based on GOLD, this is the only thing that you need to make the diagnosis, really. Not the only thing, but this is where it starts, is this ratio is less than 0.7. I'll say it again because that's important. If this ratio is less than 0.7 in an adult, then you can say, yeah, you've got obstructive lung physiology. And there was a study that came out in Chest in 2007, and it looked at the accuracy of that diagnostic cutoff for the FEV1 FVC ratio for diagnosing disease in younger adults. And they took population data from the NHANES, and they found that among young adults with FEV1 FVC ratio below 5th percentile, so basically young adults with COPD, this ratio is very low. They have obstructive lung disease. They found that the cutoff of a ratio of 0.7 misidentified 1/2 of young adults with obstructive disease as being normal. So it was a false negative. So they're saying the sensitivity of that 0.7 cutoff is not adequate in the younger population, but that it generally does apply to the older population. It's about 80% sensitive in people above age 65. So this study concluded that the GOLD guidelines of a ratio less than 0.7 misidentify about 1/2 of younger adults as normal. So that's a big deal clinically. You're not going to get asked this on your test, but understand that if you have a young patient and their ratio is normal, that might not necessarily mean that they don't have the disease. So what you want to look at in adults younger than age 65 is their Z-score. So now we're going to look at some pulmonary function tests, and we'll walk through interpreting all this. This is a good standard PFT printout, and most good PFTs are going to show you the Z-score, and that's the standard deviations away from the mean. So a Z-score of -2 would mean they're 2 standard deviations below the population mean for their demographic, which would mean that they're below the 5th percentile. So when you get a PFT printout, you look at your FVC, you look at your FEV1. Really, the first thing you want to go to is that ratio if you're concerned for COPD, because it's going to tell you if you should do any further testing or not. If that ratio is normal, and again, if that z-score is greater than -2, then basically you've ruled out COPD at that point. Um, but if it's abnormal, then you want to look at the further parameters provided by the test. Just the ratio itself is really not enough to diagnose it. Their FVC needs to be, below 80th percent of predicted. Their FEV1 also needs to be below 80th percent of predicted. So the ratio is important, but in true COPD, FVC and FEV1 are also going to be independently down, along with the ratio going down. Now, what sets obstructive physiology apart from restrictive physiology is your lung volumes. When you have obstructive physiology, then your residual volumes are going to be elevated. Your total lung capacities are going to be elevated because there will be air trapping. And those volumetric features are not present in restrictive lung disease. Everything is down in restrictive lung disease. And then there's DLCO, and honestly, that's very specific and outside of the scope of this talk. I will not talk about DLCO much. But let's go back up and look at FEF 25 to 75. This is your forced mid-expiratory flow. And the reason why I'm calling attention to this is because if you understand the forced expiratory flow and the 25 to 75, you can figure out where in the airway certain pathologies are occurring. So when we say 25 to 75, we take the total time of someone's spirometry test, which, you do a breath in and a breath out, and it might take you 4 seconds or something. So let's say in this 4 second breath, the 25th percent mark, or you're going to be 25% of the way done with that test at 1 second. So in that 4 second breath, your FEF 25 is going to tell you the velocity of flow over that first second of that 4 second breath. Your FEF 25 to 75 is going to tell you the velocity of flow in the middle of that breath, from the 25th to the 75th percent of time of that breath total. So this is a proxy for bronchiolar disease and small airway disease, and FEF 25/75 is going to be definitely diminished in patients who have COPD and asthma. It's a measure of small airway function. And to put it in some context, let's say someone has a tracheal issue. Let's say that they have tracheomalacia or they have a tracheal mass that's obstructing their airway. They're going to have a lower FEF 25 right there at the first part of exhalation because that trachea is earlier on in the airway. And so you're going to notice it earlier in the breath if there's a problem there. I hope this is making sense. But anyway, my take home there is that your forced mid-expiratory flow is a proxy of small airway function, and it shows the burden of bronchiolar disease. By the time you're getting to your FEF, 75 to 100, that's the last little bits of air in your lungs. So that's a proxy for alveolar function. So early on in the breath, you're getting a good idea of large airway flow. In the middle of the breath, you're getting a good idea for the medium-sized airway, the bronchiolar flow. And at the end of the breath, you're seeing how their alveoli are doing, puffing that last little bit out. So now let's go over and let's just look at the flow volume loop. You got flow on the y-axis, you got volume on the x-axis, and you're measuring this by using a device that the patient is breathing in from and blowing out into, kind of like a drinking straw. And so if the device is measuring flow, then positive flow is going to be flow going towards the device. So that's how you keep your exhalation and your inhalation straight on one of these. I know if you haven't seen a bunch of them, it can be like, well, which is heads and which is tails, which side's breathing in, which side is breathing out. So if you just remember that positive flow towards the device is breathing out and exhaling, then you'll always be oriented right when you're looking at one of these. And yeah, that's about all I have to say about this. Other features of your spirometry printout. You're going to be doing pre and post bronchodilation on just about all of these patients to see if they're responsive. So you get the pre and the post scores for each of your different measurements, and you get your lower limit, upper limit of normal. Those are really not, those are not important. Predicted. Really, what you want to look at is your percent of predicted in your Z-score. And for any given one measurement, for any one of these rows, less than 80% of predicted is generally accepted as pathologic or abnormal, I should say. Less than 80% of predicted is abnormal. But again, for the diagnosis of COPD, generally speaking, you're looking for an FEV1 FVC ratio less than 0.7. So if it is less than 0.7, then your next step as a clinician is to figure out if it's reversible with a bronchodilator. Because if it is, then you could be dealing with asthma and not COPD, because asthma is a reactive airway disease that gets better with bronchodilator therapy. And we define reversible as improvement of 12% or greater after the bronchodilator inhaler is given. So if there is no improvement and the patient stays low, that ratio stays low, then you just diagnose COPD. So now you have to describe it. And we can describe the results of PFTs based on their physiology. Three big groups of abnormal physiology: obstructive, restrictive, and mixed. In a purely obstructive physiology, your FEV1 to FVC ratio is going to be less than 80%. Again, 80%, less than 80% is abnormal, less than 70% for the ratio is diagnostic for COPD. So purely obstructive, only the ratio is going to be affected. Your vital capacity can sometimes be normal. In a purely restrictive physiology, your vital capacity is going to be down because you can't get as much air into your lungs, but your ratio will be preserved because there is no air trapping. So your FEV1 or your expiratory flow in 1 second should remain normal, robust in a purely restrictive physiology. But in a mixed physiology, which is probably the most common, most people with lung conditions have a mixed spirometry deficits, then both your FVC and your ratio are going to be less than 80%. So when you write up your report, you're going to say the patient has mixed lung physiology based on FVC and ratio, both less than 80%. So then you want to talk about how severe is the, obstructive pathology you just diagnosed. You can call it mild, moderate, severe. These are just some cutoffs, and you can kind of ballpark it too. Nobody's really going to be, proofreading this too hard, but just to communicate with other providers and with everybody else, you want to say how severe it is. So then after you've characterized the severity of their physiology and you've diagnosed your COPD, you want to stage your COPD. And we do this according to the GOLD assessment tool, which says, after you have your FEV1 FVC ratio less than 0.7 that doesn't reverse with a bronchodilator, then you want to ask some clinical questions. And you want to figure out their symptom severity and their history of recent COPD exacerbations, because that's going to allow you to choose what therapy they need to be on in terms of daily inhalers. So if someone's had 0 or 1 exacerbations within the past year, then they're going to be in this A group or this B group. But if someone has had more than 2 exacerbations, or at least 1 leading to hospitalization, you can go ahead and put them in this E group, and that E stands for exacerbations. And then again, if they are not having frequent exacerbations, then you can, further subclassify them based on the severity of their symptoms. And their symptoms are going to be based on the easiest way to get a formal number on this is going to be this thing called the MMRC, or the Modified Medical Research Council Dyspnea Scale. And this is easy and great. It's a 1-question assessment, and it's on MD Calc. And really, you just ask them, tell me about how your shortness of breath presents. How often do you get short of breath? What do you have to do to get short of breath? And, within a couple questions, you can figure out, oh, well, I get short of breath walking to my mailbox, or I only get short of breath when I have to go upstairs, or I'm short of breath sitting in my armchair. So that helps you to kind of, again, grade slash stage the severity of their COPD. And just side note here, you gotta be cognizant of heart failure also presents with dyspnea and confound, results of this assessment. So once you've diagnosed COPD, how do you treat it? Generally, the answer is daily bronchodilator inhalers. Here's the gold treatment recommendations. They say that, if someone has mild COPD, uh, low symptom severity, few exacerbations, then you just put them on a bronchodilator. Sure, they don't really get too specific on which one, that's up to your clinical judgment. But they specify that if someone's got increased symptom severity, they need to be on a double inhaler treatment. So they need to be on a long-acting muscarinic and adrenergic beta uh, agonist or antagonist. Oh God, I'm blanking. But they need to be on a LABA and a LAMA. So double inhaler therapy is basically the standard of care these days. And I do want to call attention to the GOLD guidelines don't necessarily say, they say for this group of people having frequent exacerbations, they don't specify that you need to be on an inhaled corticosteroid. So that's something that's evolved over the past decade or so. I think it used to be more common than it is now. We're trying to kind of pull back on the steroids unless people really need them because the steroid inhalers have a little bit of a side effect profile. And we want to try to prevent adverse events when we can. I read a lot about blood eosinophil count, and that's also getting into the weeds. So I'm not going to talk about that too much, but generally be aware that there's growing evidence that eosinophils are a valid biomarker for gauging the responsiveness of someone's pulmonary disease to steroids. So you get a CBC, you see their eosinophils, that can help guide treatment. So that's how the GOLD guideline recommends that you treat diagnosed COPD according to how you grade their disease. Let's look at the American Thoracic Society Pharmacologic Management Guidelines. These are from 2020, and these are a little bit different from the GOLD guidelines. Three big recommendations from the ATS. Number one, they recommend LABA/LAMA dual inhaler combination therapy over monotherapy in all patients with COPD who complain of dyspnea or exercise intolerance. And this is a strong recommendation. So let's compare that again to the GOLD guidelines. This group A, they're saying, if they only get dyspnea when they're hurrying or walking up a hill, basically with light exercise, moderate exercise, you just put them on a bronchodilator. But the ATS guidelines are really saying that basically everybody with symptomatic COPD should be on a dual inhaler. So, if I was going to get a test question on this, I'd put someone on a dual inhaler just to be safe. I think that that's the direction the field is going in. There's a lot of evidence. There's over 20 randomized controlled trials comparing dual to mono inhaler therapy head to head. And the data is pretty strong that being on a dual inhaler therapy will lower your risk of exacerbations without a significant increase in likelihood of adverse events. So it seems safe and effective to put someone on double inhaler therapy from the get-go if their COPD is pretty routinely symptomatic. The next 2 points in the ATS guidelines talk about inhaled corticosteroid therapy, which that's the main reason why I included this because the GOLD guidelines don't really mention that. And ATS says that they recommend triple inhaler therapy with a corticosteroid over dual therapy in patients with one or more exacerbations in the past year, period. requiring antibiotics or oral steroids or hospitalization. But, I mean, I'd make the point that if you're not doing one of those three things, is it really an exacerbation? I don't know. It's pretty weak exacerbation. So basically, anyone who gets an exacerbation, according to the American Thoracic Society, should be on a daily inhaled corticosteroid. And then they also say in their third bullet point that in patients who are receiving triple therapy with the addition of that inhaled corticosteroid, they suggest you can stop that steroid inhaler if the patient has had no exacerbations within the past year. So again, de-escalate therapy if the indication is not persistent. And those are both conditional recommendations. Again, we don't really have enough data to make strong claims about including or not including the inhaled corticosteroid, which is probably why the GOLD guideline doesn't reference it. But that at least answers some questions, answers some questions the GOLD guidelines don't. So let's talk about COPD exacerbations. An exacerbation is, for the layperson, defined as an acute change in symptoms causing a change in treatment. The GOLD guidelines will define it as an event characterized by dyspnea and or productive cough that worsens over the course of 2 weeks or less, which may be accompanied by tachypnea or tachycardia. So a very subjective definition, even though it does have some specific features in there, it's still a pretty subjective definition. How bad's the dyspnea? How bad's the cough? It may be accompanied by tachypnea, tachycardia. But for your purposes as a clinician, are the symptoms bad enough to where you're going to do something differently? If the answer is yes, then you could probably safely call it an exacerbation and nobody is going to question you. So the patient will come in with, again, acutely worsened dyspnea. They'll say, it got worse and it hasn't gotten better. They may or may not have a productive cough. They may have tachypnea, tachycardia, or hypoxia. I want you to understand that COPD exacerbation is a clinical diagnosis. There's no gold standard lab or test that will make this diagnosis for you. Now, obviously, if you get an arterial blood gas and somebody's got a blood oxygen of, 50 or something like that, this is an acute exacerbation. But for most people who walk into your outpatient clinic, you're not going to be getting an ABG on them. But those adjunct tests are available as needed, mostly to rule other stuff out, because a heart failure exacerbation can mimic a COPD exacerbation. A pulmonary embolism has strong overlap with the clinical features of COPD exacerbation. So really, you're ordering tests to rule out other things, and you're making the diagnosis of COPD exacerbation if you're reassured that something worse is not going on. Acidosis, if you do get an ABG, indicates a severe exacerbation. Someone presents to the emergency department, they've got acute dyspnea. It can get, pretty severe. People can require mechanical ventilation even, just to kind of bridge them and taper them off until you treat their exacerbation. So how do we treat it? Well, in the outpatient setting, put them on a prednisone taper and see them back in a week, see if it improves. And generally, you want to do 40 milligrams of prednisone orally every day for 3 or 5 days or something, and then just kind of walk them down, walk the dose down, go to 30 a day, go to 20 a day for a few days, go to 10 a day. And antibiotic treatment is going to be indicated if the patient has a productive cough. So if someone comes in and says, Doc, it's difficult to breathe, started 8 days ago, hasn't gotten better, I think it's happening again, but I haven't been coughing anything up, then you don't necessarily have to start those patients preemptively on antibiotics. So for purposes of a test, antibiotics are indicated if there's a productive cough. And you want to, get a sputum sample, culture, et cetera, if you can. But generally, if they say they've been coughing up, a bunch of stuff, then you just start them on, azithromycin or, a beta-lactam or something like that. And side note, asking someone how much they're coughing up, people will tell you, pretty accurate answers, actually. You can generally say, like one can of Coke. Like how much would you fill up out of a can of Coca-Cola? They'll say, oh, I'd probably fill up a half a can of soda, or like, oh, like none, nothing at all. Like I've been coughing, but it's dry. So try to get them to quantify the productivity of their cough, and that'll give you a good proxy quickly for the severity of their ongoing disease. Now, treat them with steroids. You can do intravenous steroids if it's bad enough. Someone presents in fulminant respiratory failure, you should probably just give them intravenous steroids. But beyond the steroids, people are probably going to require supplemental oxygen if it's bad enough. So you want to start with non-invasive ventilation. You can do nasal cannula up to 15 liters a minute. You can go to an oxygen mask, allows people, get their mouth involved with breathing. You can go to a high flow nasal cannula, and that can also have heated, humidified air on it. If they're still not responding to the high flow nasal cannula, you want to put them on positive pressure ventilation. So you can do that non-invasively with BiPAP, which is a mask that is going to force air into the lungs, basically, and the pressure is going to help keep airways open, which again in COPD, the airways want to collapse. There's mucus plugging and there's, loss of elasticity. So these airways are going to collapse and not want to stay open. So by pushing positive pressure into the lungs, you're keeping bronchioles open so that ventilation can proceed. And, if someone's non-responsive to BiPAP, they're still satin, 86% or whatever, they're just not looking good, then you may even make the move to, sedate, intubate, mechanically ventilate some of these patients. I want to talk about one last little point clinically before we go back to the SDL. That's home oxygen evaluation. Patients with, moderate, severe, long-standing COPD may be candidates for home oxygen therapy. And home oxygen has been shown to have a quality of life and I think even a mortality benefit. It's a very proven therapy, a lot of data on it for patients with COPD. It helps them out. They do better with it. They have better exercise tolerance, better quality of life with oxygen if it's indicated. So the way you figure out if they need oxygen is you walk them around the hallways for 6 minutes while they're wearing a pulse ox. And if they desaturate, then check, they just earned some home oxygen. And the reason why we use this test is because it's what CMS reimburses for. So this is for their national coverage determination for the home use of oxygen pulled from their website, which says that patients exhibiting hypoxemia are defined as, first of all, an ABG is the gold standard. So if someone's hypoxic on an ABG, yeah, they're hypoxic. But, again, you don't have ABGs on people showing up to your clinic. So what do? You walk them for 6 minutes with a pulse ox on their finger, and you see if their arterial oxygen saturation dips below 88%. And if it dips below 88% as taken during exercise, then according to CMS, they'll pay for their home oxygen now. And again, most of your patients are going to be elderly who you're even doing this test on anyways, so they'll probably have Medicare. So that's why we do what we do with respect to doing a home oxygen test. Usually, just 2 liters, and there's farther stratifications for treatment. Do they need it daytime? Do they need it nighttime, all the time, only with activity? And this is a really good paper that breaks down the walk test and also talks a little bit about, who should get what type of oxygen. So those resources are readily available and easily discoverable online. If you ever want to implement this into your clinical practice, it's real easy. Just have someone walk the patient around and document your protocol, how you did it, document if they desaturated or not. So that's a lot of information. Let's get back to the SDL. Chronic obstructive pulmonary disease is progressive and irreversible, and it's caused by obstruction of airflow out of the lung. And again, that's caused by mucus plugging and by loss of elasticity. The 2 clinical phenotypes are chronic bronchitis, mucus plugging, and emphysema, loss of elasticity. And both of these present the same way with a decreased FEV1. You can't move air out of your lungs. So you diagnose an obstructive physiology, and it's because of air trapping. Spirometry makes the diagnosis. Most COPD patients have a combination of these features. Mentions asthma is not a type of COPD. That's a murky, unclear, and debatable point. Asthma has obstructive physiology, period. Like, I'll just leave it at that. Um, COPD is the fourth leading cause of death in the United States. Affects 15 million people a year. Most people have it because they smoke cigarettes chronically. I'm not really sure what the data says about vaping, but I would assume that in, 10, 20 years, we'll have some better answers on that. You can get it from, other reasons. You can get it from, again, exposures to, coal, asbestos, etc., other respiratory type things. You can get it because of alpha-1 antitrypsin. So then we talk about chronic bronchitis, which is defined as a chronic productive cough lasting at least 3 months per year for at least 2 consecutive years without another identifiable etiology. And if somebody has, cystic fibrosis or if they have tuberculosis or something, you got to make sure that there's nothing, super rare going on. But that'll probably be, more obvious. If you can't rule or you can't diagnose anything out and they do have this chronic productive cough, you can say they've got chronic bronchitis. Tends to be in older people. About 90% of cases occur in smokers. Cigarette smoke, again, causes friction on the airway. Your airway reacts by making more mucus to lubricate itself. The mucus sticks up your mucociliary escalator, and that leads to defective clearance of sputum, so it stays down in the lungs instead of going up and out like it should. And when it stays down in the lungs, it can form plugs, mucus plugs in your small bronchioles, and this obstructs flow in your airway. So not only does that directly lead to your reductions in FEV1 and FVC and the ratio, that can also create potential for pneumonia because if you have, I'll compare it to acute cholecystitis. You get a gallstone, it plugs up the neck of the gallbladder. There's bacteria in your gallbladder. Those bacteria swell, cause inflammation. If untreated, it'll lead to a gangrenous gallbladder. You'll just perforate the wall of it eventually. Same thing in pneumonia. You get a mucus plug blocking up a bronchiole. There's pathogens in your airway. So if you've just got this blind cul-de-sac of bacterial growth, then they'll proliferate, and that leads to a pneumonia. Chronic bronchitis, you get chronic inflammation. Slowly, the walls of your bronchi fibrose, they scar up, and this leads to a fixed airway obstruction, which number one means it doesn't respond to bronchodilators, so it's not asthma. And number two, it's irreversible. So again, it's not going to get better over the course of a lifetime. Some histology here, just kind of showing you again, the thickness of the gland relative to the overall width of the bronchus and kind of the Reed index there. A Reed index of greater than 50% is abnormal. I think that this is probably, testable for in-house exams. It'll be a 2-foot putt, just tap it in. That's an easy question, but you'll never see this on boards. It's kind of too far in the weeds. Clinical presentation of chronic bronchitis, persistent cough. For how long? At least 2 years. How many months a year? At least 3 months a year. Okay, and it's productive of sputum, typically clear. If you ask a patient what color is the stuff you're coughing up and they say, oh, it's clear, generally speaking, you're not concerned about an airway infection. But if they say, oh, yeah, it's green, and that's different, it's not always like this, then you may be concerned about an acute pneumonia. These patients get dyspnea. You get an ABG. They've got decreased resting levels of blood oxygen, increased blood CO2. Cyanosis, that's not, that's extreme and end stage. That's the extreme manifestation of chronic bronchitis. They will have wheezing. They may have wheezing. Can lead to cor pulmonale. Talk about that a bit later. Good photos here of your airway in chronic bronchitis. Here on the left is a nice normal airway with a very thin bronchial wall. You see bronchial wall thickening here in this middle photo. Again, it's reactive inflammation in response to a bunch of cigarette smoke. And you can see here in the rightmost picture how over time that very clearly leads to a compression of the diameter of the lumen of a bronchiolar airway versus this on the left here that's nice and wide open. You could drive a truck through that. Microscopic appearance, we covered that. Okay, that's chronic bronchitis. Let's talk about emphysema. Emphysema is loss of elastic recoil, causing your airways to collapse because they're no longer held open by elastic force. And whenever those airways collapse, there's also some free radical damage to alveoli. There's inflammatory changes. Your alveoli blow up and dilate and get large, and the walls between them start to break down. And that, in combination with your terminal bronchioles collapsing, manifests as air trapping, which leads to a chest X-ray that looks like this. So again, the alveoli breaking down and your airways collapsing, air gets stuck in the lungs. This is what happens. Emphysema is largely confined to smokers and patients with alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency is responsible for 1 to 2% of cases of emphysema. Generally, you got to smoke for a long time before you see either chronic bronchitis or emphysema symptomatically manifest. Pathogenesis of emphysema. It's a consequence of decreased elasticity as a result of, number one, imbalances between elastase and anti-elastase. So an ACE just breaks something up, and an anti-ACE would stop the thing that's cutting apart your proteins. So elastase breaks apart and degrades elastic proteins. When you smoke, elastase goes up, anti-elastase goes down. This is mediated by immune cells. Number two, imbalance between free radicals and antioxidants. Smoking depletes free radicals. Tobacco smoke activates neutrophils. Neutrophils degranulate, resulting in the release of elastases from neutrophils and matrix metalloproteinase from macrophages. Anytime you see a matrix metalloproteinase, you know it's involved in connective tissue remodeling. And these factors lead to destruction of elastic fibers normally found in the alveolar walls. Additionally, smoking perpetuates the oxidant-antioxidant imbalance in your lungs. Inhaled cigarette smoke activates INOS, inducible nitric oxide synthase, which leads to peroxynitrite generation. Peroxynitrite's a free radical. You deplete your antioxidants, you're more susceptible to free radical damage down in your alveolar walls. Again, what does this look like on a histology slide? It looks like this right here. On the left side of the screen here, you've got large alveoli because their walls are getting degraded because of free radicals. And the loss of elastase really more so has to do with the terminal bronchi and those being held open. That also affects alveoli as well. Again, you got increased static lung volumes because you got more space for air to collect down distally, and your terminal bronchioles collapse. because they're no longer being held open. In alpha-1 antitrypsin deficiency, antitrypsin is a protease inhibitor. So if you don't have a protease inhibitor, you have increased protease activity. What you really want to know about this is that it's autosomal codominant. You just say autosomal dominant on a test. And there's a few different alleles or phenotypes to know about. I might have seen, one, maybe two questions about this in my whole time. So it's testable, but not especially. You'll see it again in gastrointestinal block because alpha-1 antitrypsin can affect your pancreas, your liver, GI organs as well. So there's an M allele, which is a normal person phenotype. There's a Z allele, which is a diseased phenotype. People who are homozygous for the Z allele get early emphysema with a median age of diagnosis of 38 years. So again, whether you smoke or don't smoke, if you have alpha-1 antitrypsin, you'll get pulmonary disease earlier. Even non-smokers get it. Types of emphysema, probably see a question about this. Looking at the distribution of it, where is it in the respiratory anatomy? We can call it centroacinar. That's here in B, where it's in the middle of the respiratory unit, but doesn't really affect distally the alveoli. We can call it panacinar when it affects the whole respiratory unit. And this is more likely to be seen in alpha-1 antitrypsin. Or we can call it distal acinar. And this is interestingly associated with primary spontaneous pneumothorax. Take a side note, talk about pneumothorax for a bit. Pneumothorax is air in the chest cavity between the lung parenchyma and the parietal pleura. And so when you get air in there, it's because of a hole in the airway. Okay, so you can get primary or secondary spontaneous pneumothorax. You can get traumatic pneumothorax, different entity. We're talking about spontaneous pneumothorax. People who get primary spontaneous pneumothorax, it just happens to them. They don't have underlying respiratory disease. People who get secondary spontaneous pneumothorax, it's because they have long-standing COPD causing emphysema, and they get blebs that rupture, and that's where the air comes from. Now, people who get primary spontaneous can also get blebs that rupture. It's just typically they have one or two, they have a small area of isolated affected lung. And factors that could predispose a bleb to rupturing or predispose to the development of blebs would be, marfanoid habitus. Typically, it's a tall, thin male in his teens to age 30 or so who gets primary spontaneous. Women get it too. Job factors affect it. If you're an airline pilot, if you're a scuba diver, so if your job involves pressure changes, that can be a predisposing factor to developing a pneumothorax. Astronauts get it. Ask your patient if they're an astronaut, they'll get a kick out of that. Treatment of a spontaneous pneumothorax. Again, a pneumothorax caused when one of these big blebs just pops spontaneously, so you get air in the chest. They may need a chest tube if there's enough air in there, and depending on how symptomatic they are. You want to put them on supplemental oxygen. That's proven to help. And you may talk about resecting a diseased part of the lung if there's obvious bleb disease. Back to the text. Centroacinar emphysema is seen predominantly in cigarette smokers. It's because your terminal bronchioles kind of sponge the majority of the damage from cigarette smoke. So you might have heard this before, but filters on cigarettes. Um, Filtered cigarettes are actually a little bit worse for you because so I'll walk that statement back. I don't know if they're worse for you personally, define worse, right? But when you smoke a filtered cigarette, the filter gets rid of the macro particles. So only the microparticles are left. So now all of a sudden you've got a whole bunch of really tiny particles. So a filtered cigarette is going to go deeper in your lungs than an unfiltered cigarette because, the macro and the very small particles will all be colliding with one another, and so stuff won't make it as distal in the airway. But, people smoke ultra filters and, oh, it's better for me. It's like, no, it's not better for you. It's actually probably worse for you because now your alveoli are getting barraged by very tiny, tiny particles that wouldn't otherwise make it all the way down to your alveoli if you didn't have that fine filter on the cigarette. Um, Centroacinar emphysema tends to be in the upper zones of the lung because smoke rises, air rises. And you can contrast this with panacinar emphysema, which tends to be in the lower lung fields and is seen in alpha-1 antitrypsin. So in the right patient, if they've got a pattern of lower lung involvement with their emphysema, and you can see it pretty good on a CAT scan, then you may be thinking, this person's got a genetic predisposition to this, versus the classical pattern that's going to be, again, more upper airway dominant. Distal acinar or paraseptal emphysema. Again, this is when you have it on the periphery of the lung. You get emphysema, you get blebs. When it's right there on the periphery, it can pop and you can get a hole in the airway. So you get a pneumothorax from that. If it were buried in the middle of the lung, even if it ruptured, you would not really get a pneumothorax from that. You just get a larger alveolar space. Cigarette smoking does, predispose people, but again, there's a lot of predisposing factors that are not related to smoking. And then finally, you can get emphysema if you have infectious disease, inhaled irritants, etc. So on histology, what do you see? You see big dilated alveoli. You can see free-floating fragments of alveoli. And you do tend to see, this is not specifically mentioned, but more inflammatory cells, generally speaking, more macrophages and neutrophils, and they have denser nuclei than your pneumocytes do. Clinical presentation of emphysema. Similar to chronic bronchitis, just really without the productive cough. Tends to be a dry cough, non-productive. You can get muscle wasting in the late stages. The phenotype of emphysema is going to be someone who's skinny. Honestly, they've lost a lot of weight. They're older, and they do still tend to have that barrel chest with the increased AP diameter. On exam, you're going to hear decreased breath sounds. You can hear wheezing. You can hear rhonchi. Breathing through pursed lips. I used to be able to explain that. I can't really. I mean, I don't know. It's just easier to breathe when they. I think it has something to do with the pressure gradient, maybe like if you can't move air out, you need a stronger pressure gradient in order to actually move air in and out, and so that might help with that. Dyspnea with exertion, pulmonary hypertension. So, about VQ match and mismatch. If there's an area of your lungs that you're not ventilating, so V goes down to 0, then your body will compensate by taking Q, blood flow in that area of lungs, also down to 0. So if you get mucus plugging and you're not ventilating, certain segments of your lungs, or, if bronchi are collapsing and alveoli are getting destroyed, then you're going to lose capillaries. That loss of capillary resents loss of blood flow. Um, when you lose capillaries, your blood volume doesn't change, but the amount of vessels in your pulmonary system does change. So if you're trying to put the same volume of blood through less pipes total, then the pressure of blood in those pipes is going to go up. So it's the mechanism of pulmonary hypertension in people with emphysema. Again, whether it's due to capillary eradication or again because of VQ mismatch of some sorts, if they have chronic bronchitis and they've just got this atelectatic segment that it has been not ventilated for a long time, then again you can get some pulmonary shunting because of that. Death in emphysema and in COPD. Most frequent causes of death in COPD are going to be non-COPD stuff. So these people tend to have other comorbidities, right? Because it's a chronic disease. These are not the healthiest patients. They've smoked a long time, most of them. So they'll probably, have cardiac stuff, have renal stuff going. They'll have other issues beyond their COPD. But that being said, in certain patients, pneumonia can be lethal. Um, patients who fall and fracture ribs, if you have poor pulmonary function at baseline, if you can't compensate for a pulmonary injury, you're more likely to, go into respiratory failure, et cetera, require ventilation, get pneumonia, all that stuff. Um, right heart failure, if it's very severe COPD, yeah, certainly, right heart failure can be the thing that pushes you over the edge. Other forms of emphysema, pulmonary bullae. A bulla is an airspace over 1 centimeter in diameter, so it's a large pocket of dilated alveoli, and tends to be due to emphysema. These can be, you can have a genetic predisposition to them. Sometimes we see kind of like, polycystic kidney disease. There's a genetic component to that. There's genetic contributors to lung bullae as well. Um, when you see these on a CAT scan, they don't really change your management unless something really bad is going on. Most of the time, though, when you see this, it's just so this patient's got COPD. Um, if their breathing is really, bad, you can consider a bulectomy, and you can do a video assisted thoracoscopy, go into the chest, and just staple off that section of diseased lung that's not doing anything for you anyway. So it'll give your non-diseased lung parenchyma or your less diseased lung parenchyma a little bit more room to expand and work. So that's the concept behind surgery for Ebola. Subcutaneous emphysema. When people get subcutaneous emphysema, it's because there's a hole somewhere in the airway. This can be traumatic. You could have a sharp fractured rib puncture your pleura, and air could get in from the outside. This could be from the inside. Again, whenever you get a spontaneous pneumothorax, the air can spread so much to where, it distributes and dissects through mediastinal planes, rises up into the neck, supraclavicularly, can go into the chest wall. Patients can get really swollen because of this, and it depends on the size of the leak too. Maybe, and a third cause would be, I've seen it from someone undergoing like an IR thyroid biopsy, and you accidentally nick or puncture the pleura. That can be, patient comes back in 12 hours later and their neck's swollen. They've got palpable crepitus because he accidentally violated the pleura during a procedure. So when this happens, what do you do as a provider? Number one, image them, right? See if their lung is down. Because if they really have a pneumothorax and their lung is down, they need a chest tube. Look at their vital signs, make sure they're stable, all that. If everything's good, then step two is really don't freak out about it too much. Reassure the patient because they're going to be freaking out about this because it's really, it's not a everyday occurrence, right? But just say, yeah, the air tends to go away over time. It'll just dissolve. It's gas. It'll work its way out. Typically you're going to put in a chest tube. If there's a pneumothorax, you're going to put it to wall suction, and you're going to, let it be on suction for a couple days, evacuate all that air, let it resolve, let the air get out. The crepitus, when you got a chest tube on wall suction, the skin crepitus and the emphysema should slowly get better. This can take, 2, 3, up to 5 or 6 or 7 days, but eventually it improves, and then you can take your chest tube off suction, put it to water seal. If there's no air leak, then you can probably take the chest tube out. Um, An air leak in a chest tube indicates that there is still some ongoing hole in the lung, so it would not be safe to remove a chest tube that has an air leak. Um, Air leaks can also indicate that the seal around the chest tube is not adequate. So that's a big takeaway, actually. If you're planning to ever manage a chest tube, I want you to understand that there's two reasons you can have an air leak in a chest tube. Number one, there's a hole in the lung. Number two, the air is coming in from around the tube. That's it. There's really no other reasons, common reasons to have an air leak on a chest tube. That's about it. Lastly, making the diagnosis of COPD. Talked about this a bit. You know, your FEV1 to FVC ratio is less than 0.7. That's per the GOLD guidelines. Or your FEV1 to FVC ratio is going to be greater than 2 standard deviations below normal for population, and that's going to be per the ATS guidelines. If you get an ABG, you can see hypoxemia, hypercapnia. Patients who have had COPD for a long time, they might just live in a hypercapnic state. I've seen, certain patients whose ABG was just normally at a PaCO2 of 55 or 58 or something like that. So that can be normal at people. And also, they're going to have a decreased oxygen saturation at baseline. So 88 to 92% is going to be your target for supplemental oxygen therapy in these patients with COPD. You don't want to over-oxygenate them because they're not used to having that much oxygen. So what it'll do is it'll decrease their respiratory drive and it'll slow down their breathing and actually make things worse if you keep these patients on, 99%. So understand that any COPD patient who's diagnosed, it's in the chart, they need to be on 88 to 92%. That's their goal. You can have polycythemia from chronic hypoxemia. Oxygen goes down, erythropoietin goes up, red blood cell count goes up. This is a false polycythemia. This isn't what we call polycythemia vera, which is like I forget the word for it. It's a myoproliferative disorder, basically. I think that's the word for it. It's a blood cell lineage neoplasm. But hematocrit will be up. You'll get a compensatory metabolic alkalosis in anyone with, a long-standing respiratory alkalosis. Your kidney's going to excrete hydrogen and bicarb in the blood is going to go up because, in your kidneys, if you want to pee out hydrogen, which you would if you have an acidosis, you have too much hydrogen, so your kidneys want to pee them out. So if you want to do that, then you know that anytime you move ions across a cell membrane, it's got to be electrically neutral. You have to balance charges. So one way you can accomplish this is by moving a positive and a negative charge out the same side of the cell simultaneously, or you can move a positive charge this way and a negative charge out the cell the other way in structures such as, the glomeruli, in order to keep the cell electrically neutral. So when kidneys excrete hydrogen, they move bicarb out the other side of the cell and it goes back into the bloodstream. So that's where the alkalosis comes from in patients with long-standing respiratory acidosis. Imaging, you'll get plenty of reps of this outside of this lecture. Clinical phenotypes, I think that we've covered these already. So that's my lecture on COPD. Appreciate your time. Go do a good job on the test.